is it's all about the organs. We have two abstracts to be presented. The first abstract will be presented by Dr. Skand Shekhar. He's from the National Institute of Health. The title of his talk is Abnormalities of Pituitary Imaging and Associated Endocrine Disorders in Erdheim-Chester Disease.
Okay, thank you, Ron. And I'd like to welcome you all back from the most important session, which is the lunch session. Today, I just wanted to turn the focus of this audience to a comorbidity that is seen in these patients quite commonly, which is an abnormality of both pituitary function and structure, and wanted to share our experience at the NIH with these patients. I'm thankful to my co-authors who are listed on the screen. So to remind the audience, I think the landscape has changed a lot, and I don't think that it's 1,000 cases or less worldwide anymore. It's obviously more than that. But it's important to also understand that this disease has been constantly evolving, and our understanding of it has been evolving ever since 1930, when doctors Erdheim and Chester talked about it for the first time. And I don't think this audience, again, needs a reminder, but there are molecular genetic defects in RAF and MAP kinase pathways, leading to histiocytic infiltration of various organs. And so in that context, it's important to recognize that there is a high burden of endocrine disorders in patients who have Erdheim-Chester disease, which includes thyroid dysfunction, diabetes insipidus, adrenal dysfunction, hypogonadism. There's also a lot of other endocrinopathy, which I have not listed out here. And this was sort of the initial publication by Juvie back in 2017, which kind of just illustrates the molecular defect and as it translates into various organ damage pathologies. So on the one hand, you see skin involvement and bone involvement. On the other hand, you see fibrosis of the lung and retroperitoneal tissue. But most importantly, what I'm trying to focus on today is the CNS involvement and how does that impact endocrine function. This slide again shows the same thing as more cross-sectional radiographs. And again, the hairy kidneys, the periaortic involvement, the fibrosis of lungs is very important. But unfortunately, one of the major problems in this disease is the CNS involvement. And at this point, I think it's prudent to draw your attention to the involvement of the hypothalamus in the pituitary, which tends to be a prominent manifestation and very frequently an irreversible one. So to remind everyone in the audience what is really going on at the hypothalamus and pituitary as it relates to endocrine function, I think it's important to kind of consider that hypothalamus and pituitary work hand in hand to trigger the release of various hormones, which ranges from growth hormone, which is essential for our well-being and growth, to gonadotropins that lead to the normal maintenance of reproductive function and endocrine function. And it also goes on to functions of the adrenal gland, so things like cortisol and aldosterone. On the other hand, there is thyroid hormone, which is obviously a very important hormone in the body. And then there is vasopressin, and vasopressin is what controls the sodium and water balance of our bodies. And so if you think about this, any defects that lies upstream of this will have far-reaching consequences at various organ systems. And so it's sufficient to say that the pituitary gland is the master endocrine organ, and it is responsible for a host of endocrine functions. And any disruption in one of these functions will have consequences. Deficiency of vasopressin is a well-known manifestation, and it manifests as central diabetes insipidus. And I'd like, again, the audience to just note that the name of this disease has changed as of 2022, and it is no longer called central DI. It is called arginine vasopressin deficiency through a consensus statement across Europe as well as the United States. Further, there is deficiency of various other organs, other hormones, and you can have things like hypothyroidism, hypogonadism, and adrenal insufficiency, which is fairly common in these patients. And going back to the histiocytic infiltration of the CNS, Obviously, there are pituitary consequences and downstream consequences of that. One of the things that you can actually see is abnormal pituitary imaging, which can be accompanied with biochemical abnormalities, but unfortunately, this has not been well described previously. Also, what we do not know about this entity is its association with various demographic characteristics, with biochemical function, with molecular defects, and markers of inflammation. And so we hypothesized that there was a high burden and a high prevalence of abnormal pituitary imaging in Erdheim-Chester disease that is associated with a high burden of pituitary endocrine disorders. There were two study aims. The first was to determine the frequency of these pituitary imaging abnormalities in patients who had a biochemical confirmed diagnosis of ECD. And secondly, we wanted to assess the correlations that exist between abnormal pituitary imaging and various other covariates. The current study is a subset of the NIH cohort, which was started in 2011. And the present study is a cross-sectional analysis of this cohort that was enrolled at the NIH Clinical Center in Bethesda, Maryland. And the last patient was enrolled in 2018. All patients that were enrolled had biopsy-proven Erdheim-Chester disease. And again, I'm not going to repeat this, but again, biopsy was performed in all of these subjects, and all patients were screened for BRAF V600 mutants. Those who had tested negative for BRAF V600 were also tested for some of the other MAP kinase genes that are listed here. Importantly, one of the strengths of our study is that all of these patients had some form of imaging of the pituitary, and a large majority, it included MRI with and without contrast. And 5 of these individuals were not able to have MRIs, and so they had CAT scans. And these scans were all reviewed by a neuroradiologist who was board certified, as well as confirmed by myself and my colleague at the NIH who have a special interest in neuroendocrinology. All of our subjects had testing for their thyroid function. We established the diagnosis of DI based on their clinical course and some of the previous biochemical features. Hypogonadism was defined as a low testosterone in the morning or estrogen in the case of women. And then we were also testing for other hormones on a more selective basis. We defined the number of endocrine deficits, which I'm going to talk about, as the sum of all pituitary-related endocrine deficits. So this is our study population, consisting of 61 subjects with a mean age of about 54 years. The mean BMI was also elevated. So again, there's a high burden of patients being overweight, at least initially. And a majority of our subjects had mutations in the BRAF V600 pathway. Importantly, it's prudent to note that there was a high burden of panhypopituitarism and diabetes insipidus in our patients, which I think is, again, very reflective of the burden of endocrine disorders. Looking at the abnormal pituitary imaging subjects, so almost 47% of our patients had some form of abnormal pituitary imaging, even though this was not previously recognized. But on close scrutiny, we established this number. And it's important to note that these patients were younger than those who had normal pituitary imaging, and this difference was significant. There was also a higher burden of endocrine dysfunction in these patients. So there was higher panhypopituitarism, there was higher DI, and the number of endocrine deficits was much higher. But there were no differences in sex distribution, BMI, or BRAF V600 status. In terms of imaging abnormalities, in addition to the loss of the posterior bright spot of the pituitary that is very commonly seen, we found that the thickened pituitary stalk was a very common abnormality of pituitary imaging, followed by abnormal enhancement, a small size of the pituitary, stalk abnormalities, and a range of other abnormalities which were also seen in these patients. This slide shows you the various abnormalities that I was referring to earlier. And so if you pay attention to the topmost figure, you will see that this pituitary gland is extremely shrunken. And typically, it should occupy the entire cellular space. But the black portion signifies the amount of pituitary gland that has been actually lost. On the other hand, in another patient, we saw that there was this enhancing heterogeneous supracellular mass that was destroying sort of the pituitary hypothalamic structure. And finally, this is a photo of thickening of the pituitary infundibulum, which is what is seen classically. So in summary, there was a high frequency of abnormal pituitary imaging, and these patients had a high burden of pituitary deficits compared to those who had normal imaging. We also specifically noted higher diabetes insipidus and panhypopituitarism. And these results again point to abnormal pituitary imaging being associated with a younger age, a higher number of pituitary endocrinopathies and DI. And what are the implications of these findings? So first of all, I just want to mention that in the average community, there's a burden of about 10% of people. For example, in this audience, if we screen everyone, there was going to be a 10% prevalence of abnormal pituitary imaging. But in our cohort, that was almost 5 times higher. So it's obviously, visible damage that's going on. And in addition, you're also seeing this loss of posterior bright spot, thickened stalk, which is driving the diabetes insipidus that is very commonly seen. The only other previous study which I was able to compare with ours was the French cohort. And we found that our population had a higher burden of stalk thickening, a higher prevalence of pituitary imaging abnormalities. And just like them, we found that the posterior bright spot was lost most often. Secondly, I think we've talked about this in previous sessions, but CNS involvement is obviously a poor prognosticator in these patients. And I'd like to again remind the audience that abnormal pituitary imaging is a form of CNS disease. And therefore, for the folks who are not in the field of ECD, it's important that anyone who presents, for example, to an endocrinologist with DI and maybe has some white matter lesions, it's important to consider ECD on the differential diagnosis. And once ECD is established, it's also important to perform a comprehensive endocrine assessment of these patients. And finally, I'd like to say that biochemical testing should be accompanied with imaging of these patients. This was a figure we had put together based on our observations. And what you're seeing here is normal imaging being accompanied by normal endocrine function. And as there is progressive destruction of the pituitary, there is continuous loss of various endocrine axes that I had shown you earlier. And finally, by the time that there is complete loss of pituitary structure, there's also complete loss of pituitary function. So this is a spectrum, and the spectrum needs to be constantly monitored. So this is my final slide. There's a high burden of abnormal pituitary imaging in patients with ECD, and these tend to be younger than those who have normal imaging. There is also a higher burden of endocrine disorders in those who have abnormal imaging. So there is some degree of imaging and function correlation. And in specific terms, that boils down to diabetes insipidus, also known as arginine vasopressin deficiency right now, as well as panhypopituitarism in those who have abnormal imaging. And finally, this point I cannot make more emphatically that all patients who have ECD should be screened with an MRI as well as baseline evaluation of endocrine functions. So with that, I'd like to thank you all for listening in. This is our team at the NIH, and many of them have contributed to various portions of this investigation, and we published our findings a couple of years ago. So feel free to check it out. Thank you very much.
Thank you for the great talk. One question I have, we know that a diabetes insipidus can precede the diagnosis of ECD for several years. Putting your study in a reverse perspective, at what point in time would you evaluate a patient presenting with diabetes insipidus for a Diamond-Chester disease, or what point in time, what makes you suspect in the absence of other systemic symptoms?
Yeah, that's an excellent question, and it's one of the things that I feel is sort of overlooked quite frequently. I think it should be considered at diagnosis, because I think as many studies have shown that there is obviously a delay of about 4 to 5 years. So even though that number is coming down, but often these patients are presenting to internal medicine specialists and endocrinologists, and it's my community that needs to also kind of be aware. So I think the moment they present, and if there is no explainable reason, if they don't have any pituitary infection or surgery that can easily explain, I think it should be considered. And the other important thing is to consider pituitary biopsy, especially in idiopathic cases. And so we always kind of try to push our neurosurgeons in that direction so that we can have tissue diagnosis.
I have a couple questions.
Yeah.
I'm not remembering the size of the whole NIH cohort, but is it larger than 56? And is that 56 somehow enriched for people who had imaging in the first place?
Yeah, actually, so all our 61 subjects had some form of pituitary imaging. 56 had MRIs, and
so that's the whole cohort. It's not like there was 100 people.
No.
Oh, okay.
It was the full cohort. This
Okay,
was 61 was the full cohort.
And then what is your experience of the manifestation of the adrenal insufficiency? And I mean, I don't think I've ever given an ECD patient hydrocortisone like as a replacement. So
Yeah.
how do you isolate that part clinically? And
no, that's an excellent question. In fact, I mean, obviously this was outside the scope of what I discussed, but Fadi Hanashmuni, who's listed here, a couple of years ago, he published a paper and he showed that there was a 35 to 36% prevalence of adrenal gland infiltration in patients who had ECD in our cohort. And I would say, this is an underestimate, because what ends up happening is that at various points of their presentation, these patients are put on steroids and taken off it. Some of the even chemotherapeutic agents have toxicity to adrenal as well as pituitary. So I think adrenal insufficiency, whether it's because of a pituitary problem or because of exogenous steroids or because of an adrenal problem, I think it's an under-recognized problem. And I think more studies need to be done in that direction. And certainly I think that can also contribute to some of the fatigue and some of the other features that we commonly see.
I have a sort of practical question. One of the conclusions was everybody should get pituitary MRI. And in our guidelines, we say PET CT, whole body, MRI of the brain, MRI of the heart. One of the things that comes up is, the pituitary protocol MRI, I think, is different. So that's like a fourth imaging test being added. Like, is that sort of the practice everywhere to get a pituitary MRI separately or is it like or do you order
combine it?
Combine them?
You don't need to do a separate study itself. What typically happens, at least at NIH, and I'm sure at other centers too, that if you are able to include thinner slices at the pituitary level as part of the ongoing MRI brain, you don't need a special study. All you need to do is to do 2 millimeter slices at the level of the pituitary, so you can visualize the pituitary gland in its entirety. So it's not a separate test. It can be easily combined with a contrast enhanced MRI of the brain.
Okay. It was recently I did like a pituitary MRI protocol, and the discussion was that, well, because it was pituitary protocol, we don't have enough data on like the skull or the parenchyma itself to be confident about those.
Yeah.
So I just wanted
to
to
order a pituitary MRI, then you will not capture everything else. But I think what is best practice in these patients would be to combine the initial brain MRI with a pituitary sequence, and then you can look at all those components. Yeah, thank you very much.